Sam Connelly is a specialist biomedical scientist with over 5 years of experience. She's currently undertaking her MSc in biomedical science and works at Viapath at Guy's and St Thomas's Hospital and is based in hematology and transfusion. Over to you, Sam. Thank you.
Thank you very much, Selma. So, as Selma said, I work at Guy's and St Thomas's Hospital, and I'm lucky that I am exposed to a lot of patients with many different special requirements. Therefore, I wanted to present this topic today just as a back to basics and to understand why we do things. So when I was training, I was always told what to do, but sometimes the why was not expressed clearly or left out because of time. And I think when we understand why we do things, it means we are more alert, and it can help us in our own knowledge, but also for patients in our day-to-day work life. So I just wanted to start off by asking why we would provide special requirements for certain groups of patients and what we are trying to prevent. So obviously prevention is better than cure. And so some things we're trying to prevent is transfusion transmitted infections. So at-risk groups, for example, CMV. We are also trying to prevent donor exposure for some patient groups. So for children and neonates, they receive PD packs, or some patients receive apheresis platelets. Also, we want to prevent antibody production to ensure that those patients aren't at risk of a transfusion reaction. So there is loads of special requirements. And if I was to speak about all the special requirements, we'd be here all day. And unfortunately, we don't have all day, we only have an hour. I've chosen these ones to look into is because I feel like we use these routinely in the BT lab every day. And these special requirements are focused mainly on cellular components. So that is our red cells, platelets, and granulocytes. So today, my plan is to go through why these products are provided and who requires them. Also going to, if we have time today, I've got a few shot report studies just to show that mistakes do happen and we need to be vigilant when we're issuing products. So talking about mistakes, these are just some numbers from the past shot report for the past 4 years, and what these show is the figures of incorrect blood component transfused, special requirement not met, laboratory errors. So errors do happen in the lab, and as you can see from these numbers, they were rising up until 2019. So, and they're starting to come down in 2020. Hopefully that trend will continue in 2021 as well, because we want to try and reduce the amount of errors. So I've gone a bit further into this, and I've highlighted the topics that I'm going to be talking about today. So as you can see, most of the errors account for cellular components. So I have highlighted K-neg, incorrect phenotype, CMV neg, and also every year, incorrect phenotype is the special requirement not met most. So hopefully that trend will change soon. So let's go into the special requirements. And I just wanted to start with irradiation. So as I said, we're going back to basics. And irradiation is a process that exposes products to an X-ray or a gamma ray. So only cellular components, that's our red cells, platelets, and granulocytes, need to be irradiated. And the aim, and this process inactivates the lymphocytes present in the donor unit by damaging their DNA, which then leads to an inability to replicate. So therefore, this prevents the donor lymphocytes mounting an immune response in a patient. So products that are frozen, such as FFP and cryo, do not need to be irradiated, as it's extremely unlikely that the lymphocytes will survive this freezing and fractionation process. So I really like this graphic. I think it speaks a lot about graft versus host disease. And so the main aim of a radiating product is to reduce the risk of transfusion-associated graft versus host disease. So normally, typically, lymphocytes in the donor blood are normally destroyed by the recipient as they're seen as foreign, as their HLA types are different. If the donor lymphocytes are not destroyed by the recipient, the donor alloreactive lymphocytes from the transfused blood can engraft and proliferate in the recipient, leading to cytokine release and tissue damage. So this condition typically occurs 10 to 14 days post-transfusion, with symptoms that can include fever, skin rash, hepatitis, diarrhea, and pancytopenia. And this condition is fatal in more than 90% of cases. So as this is in the title, transfusion-associated condition, we aim to prevent. There are some groups that are more at risk and therefore require irradiated components. So, I just sort of grouped them into different groups because the list is very long and I find them hard to remember, so I've grouped them all today. So the first group is our neonates and infants. So some neonates will require irradiated products depending on their situation. So this can include intrauterine transfusions, so that's the red cells and platelets, routine top-up transfusion following an IUT or an intrauterine transfusion, a neonatal exchange blood transfusion, congenital immunodeficiencies in infants and children, for cardiac surgery in neonates and infants. So this might seem a bit strange, but some cardiac symptoms may be attributed to immunodeficiencies, such as DeGeorge and, sorry, I've just turned my camera off there, such as DeGeorge or Chard syndrome, and these are both rare genetic disorders. If these conditions are suspected, irradiated components should be given until a definitive diagnosis is made, and this is usually via genetic testing. And the last one is acquired immunodeficiency states in children. So routine irradiation for red cells for preterm or infants is not required other than in these circumstances. So patients treated with certain drugs, such as purine analogues, and this includes fluridine, and pentostatin. Apologies for my pronunciation if that is incorrect, as this can induce low CD4 counts that can persist for many years after they've been treated. So therefore, patients should receive irradiated components indefinitely. Also, patients treated with, sorry for my pronunciation again, altuzumab or ATG will need irradiated components. And some of the conditions that are treated with this drug include hematological conditions such as CLL and aplastic anemia. So sharing the HLA antigens between the donor and the recipient is the strongest risk factor for graft versus host disease, because as previously discussed, the HLA helps identify the lymphocytes as foreign and then therefore be destroyed. Therefore, patients receiving HLA matched components or those receiving a transfusion from a first or second degree relative are all at risk of irradiated products. So some diseases can. So the main one is Hodgkin's lymphoma, and this is a cancer of the immune system that develops from abnormal B-cell lymphocytes. And also transplant recipients. So recipients of an allogenic stem cell transplant, 7 days prior until their graft versus host disease prophylaxis is finished and the lymphocytes are above 1, they should receive irradiated products. Also, patients that have autologous stem cell transplants, and again, 7 days prior to 3 months post. And also patients undergoing CAR T therapy. So this is chimeric antigen T cell therapy, and the patient's own cells, own T cells, are collected and genetically altered to recognize target antigens expressed on the surface of neoplastic cells. And this type of therapy can lead to significant immunosuppression. So I've just taken some photos of some units just to show you how the irradiated components are labelled. So they are labelled with BRAD tags to confirm successful irradiation. The label is affixed to the component before irradiation process begins, and it has a white dot. And then this turns blue once it's complete. So as you can see, these dots are blue here. If the white dot is present, do not use a product, and it will require further investigation to why that irradiation hasn't worked as expected. So what components are selected for irradiation? So I think this is important to think as well, because obviously I've asked lots. So for red cells used in intrauterine exchange transfusions or large volumes that are irradiated must be less than 5 days old when bled and irradiated and transfused within 24 hours. And this is to ensure optimal red cell function and minimize the risk from the free potassium. So adults, the units are less than 14 days bled when irradiated, and they will expire 14 days post-irradiation. With platelets, they can be irradiated at any stage and stored for a normal shelf life. And granulocytes, they should be irradiated as soon as possible after production and then used without minimum delay. So just some questions for you guys. If you wanted to mention in the chat or raise your hand the advantages and disadvantages of irradiating products. Is there any shelf life? Yeah. Release of potassium. So the advantages that I've got is that it prevents graft versus host, transfusion-associated graft versus host disease, which is great. That is the main reason we are irradiating products, because we want to prevent that condition that is fatal in 90% of cases. And also another advantage is that irradiation of platelets doesn't actually change their clinical function. So it doesn't affect their shelf life or change their function. So that's great for platelets. So as with everything, there are some disadvantages, and you guys have said as well, reduced red cell storage. So instead of being able to be stored for 35 days, once they are irradiated, this drops down to 14 days. There is increased hemolysis and potassium leakage, because obviously the irradiation affects the DNA and can affect the red cell structure. Because of this, the potassium levels are twice as high in irradiated cells. And also, it costs more. So it costs to do this process. And also, if you are having a shorter shelf life on your unit, it could lead to increased wastage, which is, again, another cost. So I hope that's been a good, quick, brief introduction into irradiation. So just moving on to CMV. So CMV stands for cytomegalovirus, and CMV is a type of herpes virus, and it is common in patients, and with a primary infection, they are usually asymptomatic. So once infected, it can lead to a lifelong infection in all age groups, and the virus can reactivate from its latent state and is commonly shed asymptomatically in bodily secretions. CMV is very common, and most adults are exposed in early life and develop an immune response to the virus. The response will produce an IgG, and therefore, when tested, will be CMV IgG positive. Around so 50 to 60% of the population have had the virus without symptoms and are therefore CMV IgG positive. Depending on the age group, 25 to 40% of UK blood donors are CMV IgG positive. So the transmission of CMV in cellular components, so that's our red cells, platelets, and granulocytes, can lead to a primary infection or reactivation. And this is only serious in our immunosuppressed groups. So severe disease can occur from individuals with impaired immunity if they are exposed to CMV. And it affects 0.3 to 0.4 infants in the UK. And the fetuses and neonates can demonstrate symptoms such as sensorineural hearing loss, cerebral palsy, spontaneous abortion, stillbirth, hydrops fetalis, ophthalmic complications, and death. So obviously this is a serious condition for those patient groups. And also immunosuppressed patients that have previously not been infected with CMV can experience fever, shortness of breath, pneumonia, retinitis, encephalitis, and neuropathy. So this is really important that we make sure we protect these patient groups that have impaired immunity. So another way that we do this is leukodepletion. So CMV is transmitted through white cells in blood components. And in the UK, blood components have been leukodepleted since November 1999. So the UK specification for leukodepletion is that more than 90% of leukocyte depleted components should have less than 1 × 10 to the power of 6 leukocytes, and that 99% of components should contain less than 5 × 10 to the power of leukocytes, both with 95% confidence. So doing this leukodepletion therefore reduces the risk of transmitting CMV because it is transmitted through white cells. So due to this, immunocompromised patients shouldn't receive leukodepleted products and not CMV negative products. And leukodepleted is equivalent to CMV negative, and there's a small risk from both. So I've told you who doesn't need CMV negative products, so who does need CMV negative components, and mainly situations in which neonates are involved. So therefore, intrauterine transfusions, elective transfusions during pregnancy. But just to note, CMV negative requirements are not needed during labour or delivery, as these units will probably be given postpartum. Neonates will require CMV negative products up to 28 days post expected delivery date. And just bear in mind that this date may be different depending if the neonate is preterm. So we just need to account for that. Granulocytes also need to be CMV negative if the patient is CMV negative. And just to note that you should not delay emergency transfusions if CMV negative components are not available, because all the products are leukodepleted, so therefore the risk is reduced. So when we see a CMV negative product, what does that actually mean? So it means that the donors are negative for CMV IgG antibodies, and to ensure that there is a stock available for hospitals, a percentage of the donor units are screened. And the donor units that are screened are normally younger, as CMV IgG positivity increases with your age. So I'm sure most of you are aware, but just if you weren't, this is where they show CMV negative. I've just highlighted it there, so it's just below the group information on the red cells and the platelets. Just moving on to sort of my final one that I'm going to speak about today is regarding phenotype blood. So I open the question out to you guys. Who needs phenotyped blood? And when we are talking about phenotyped blood, we're talking about matching phenotypes for a transfusion. So yes, sickle patients, transfusion dependent, red cell antibodies, sickle cell disease, multi-transfused, regularly transfused antibody. So yeah, you guys I think I've got the answers. I'll just go through what, this is obviously not an extensive list, but I've just sort of collated some of the most common reasons we would need one. So patients with red cell alloantibodies. So patients can create alloantibodies by exposures to antigens that they are negative for. So this can either be from a previous transfusion or a pregnancy. And patients with alloantibodies are at risk of a transfusion reaction if the antibody is clinically significant and antigen positive units are transfused. So I've added the table, as you can see, as not all patients with red cell antibodies require antigen negative blood, as some require IAT cross-match compatible. And this is due to the antigen frequency in the donor population. So I've taken this table from the BSH guidelines, pre-transfusion compatibility procedures in the blood transfusion laboratory, and they've got loads of really good information in there. So with a few exceptions, red cell antibodies, which are likely to be of clinical significance, are those which are reactive at IAT at 37 degrees. So where antigen negative red cells are recommended, they should also receive an IAT crossmatch, which should indicate compatibility as well. So the next group is our sickle cell disease, thalassemia and chronic transfusion program. So it is recommended that transfusion-dependent patients, so thalassemia, sickle cell disease, congenital or acquired anemias, have extended phenotypes or genotypes performed prior to any transfusion. And that when the units are issued for transfusion, that the RH and K compatible blood is issued. So the reason for this is that the RH and K are the most antigenic blood group systems, and therefore matching their phenotype reduces the likelihood of antibody production. So this is to prevent the production of alloantibodies, to reduce the chance of a transfusion reaction. And also the production of alloantibodies could affect the patient's blood provision in the future. And this is particularly important in sickle cell disease, where the common RH phenotype differs from most of our donor population. So as we've seen previously, this is the most frequently adverse event reported, and it can be due to a lack of communication. So a detailed history should be obtained for all hemoglobinopathy patients requiring a transfusion. So this can include any prior alloimmunization and transfusion reactions. Clear communication between clinical laboratory staff and perhaps other hospitals is essential to ensure that appropriate blood is provided. Another useful tool is checking to see if the patient has any history on site, and this gives the results of NHSBT testing that has been performed. And so the final sort of phenotype thing that I wanted to focus on today is supplying KL-negative red cells for women under 50. And this is because K alloimmunization is the third most common cause of HDFN after RH and ABO. So the cases of HDFN caused by K immunization tend to result in severe fetal anemia. And this is because the maternal anti-K targets the fetal K-positive red cell precursors. This suppresses the fetal production of red cells. Anti-K is an important cause of HDFN, and it can occur in mothers who have had several blood transfusions in the past, or they may have been sensitized to the KL antigen in previous pregnancies. So therefore, by providing KL-negative red cells, the aim is to minimize the risk, and around 90% of our population will be K-negative, so hopefully this is quite an easy risk to mitigate. So just to show you guys again where we will find this information on the red cell unit. So we've got the Rh phenotype on the left-hand side and also the antigens that it is negative for. That's there and it's really nice and clear. And on the right-hand side, I have shown the tag that also supplies some of the extended phenotype information. So when we're thinking about special requirements, it's not all our responsibility in the lab. We need to be told in some circumstances what needs prescribing. So obviously the clinicians see and deal with the patient history, so they need to tell us if a patient requires irradiated products. Also CMV negative products if it's for a reason that we wouldn't normally supply them. And also extended red cell phenotypes, as they need to tell us that the patient is sickle cell disease or thalassemia. So give us an indication that that testing needs to be done. So as the lab, what we will do is we will select phenotyped units. So if they require antigen negative due to alloantibody, and we will also give phenotyped units for patients such as sickle cell disease or thalassemia if we are told about it and the testing is done. We will also provide red cells that are under 5 days old for our neonates that are for large volume transfusion. So this includes the exchanges and the IETs. And also we supply CMV negative components if we are told that the lady is pregnant. So I just wanted to hear from you guys, and if you wanted to raise your hand or talk in the chat, how does the clinical teams in your hospital inform you that a patient needs a special requirement? Blood status forms? Yeah, we use the same. We use the blood status forms as well. Transplant team, sorry, I'm just reading the chat, guys. Email discussion, request form. Yeah, we use request forms as well. If it's a special requirement that will need sort of long-term, so like irradiation, we will also need a status form as well. Referral from consultant. Sometimes they just state the illness. You need to be on your guard if they're just stating it. You need to make sure you're up to date. Viapath clinical note update. So as you can see, there's quite a few different various ways that the clinical teams inform us. Once we send a list of starting drugs that require irradiated components, clinical lab review. Sorry, just go in the chat. Clinical details. Yeah, as I say, that's a and some of you have stated emails. So who would be emailed? Would it be a generic email address, or would it be only seniors have access to? Yeah, generic email address. Perfect. And would everyone have access to that email address? TP account. Yeah, I think somebody's raised their hand if they wanted to speak.
So we have electronic blood ordering system. So one of the drop-down options is special requirements that they have to fill out when they order the products. But we also have paper forms that are sent down to the lab so that we can add the special requirements to the LIMS. And then we keep the paper copy in folders at both of our sites so that if we do have LIMS downtimes, we can actually search for the patient's form there and still provide the special requirements that they need during downtimes.
Oh, that's great. I think that's really important. We rely so heavily nowadays on our LIMS, and I don't think I would want to go through downtimes personally, but yeah, it's good to have that backup. Sorry, just going through, making sure I've seen everything in the chat. Did anyone else have any other things that they wanted to say? Raise their hand. And I suppose, do you think these ways of communicating the special requirements are adequate, I suppose? Do you think that you get all the information that you need? Because I know we find sometimes we have request forms and sometimes it's a bit like a tick box exercise. So you may find a 70-year-old male is coming in for an intrauterine transfusion and people don't understand the importance of filling out that request form appropriately. So I think that's super important to be vigilant as well. Yeah, has anyone got anything else that they wanted to discuss on that point? And I think it's all pretty consistent that it's either an email or a status form. So the next sort of discussion point is how are these special requirements communicated? From your status forms and your emails, are they put on the LIMS and are these checked? Oh, Leanne's made a good point. Sorry, there was just a bit of background noise there. So Leanne has said, having such variation in ways clinicians communicate special requirements makes it difficult when doctors go to different trusts. And I think, yeah, that's really important. Having variation means that things could get missed or perhaps they might not know how to do it. I know when we have rotations of our doctors and they're not sure, we always refer them to our haematology SPR so that they can be aware of if the requirement is actually needed and the correct process in how to let the lab know. We've been told it's our responsibility to check the requirements when they're ticked on the request form. So yeah, Claire, I think that is really important and to check those and also to question it. Sometimes the special requirements might not make sense. So ensure that you just check that everything is appropriate, and understanding the whys can help you interrogate those forms and make sure that they are requesting the correct requirements. So yeah, add the patient record onto LIMS. So I'm lucky at the moment to use Viapath, and that is really good at adding special requirements and being able to block things from issue. Perfect. And somebody said, we have it built into our LIMS. When we book in or go to issue it, it flags up on our screen, which forces us to look at it before we can issue anything. Alana, does that block you from issuing, or does it just flag you to alert you that you need to issue those products? Did anybody want to raise their hand and speak? And I think it's pretty consistent. The LIMS does a lot of storing our information for us, so they can hold the flags. And I think having a backup paper copy. Sorry, it's just a bit of a background noise. You have to click yes to proceed. Ours blocks you from issuing non-rated products. So yeah, I think if it blocks you, that's really good. I think alerts, sometimes people can just not understand the importance of them. So yeah, I think it's really important that you take in all the flags when you are issuing blood. So yeah, is everyone happy with that point? Ours here is the same. We received the blood status form and it's inputted onto the LIMS. This is done by one BMS and then it's second checked against that second check to make sure that we've put in all the special requirements correctly. And then that's filed. So as we've got a bit of time, I've just collated some case studies. I had a look through some shop reports and sort of just wanted to see where the special requirements weren't met. And I think seeing errors shows that you can learn from mistakes and learn from these errors. So this first one is from SHOP 2019, so quite recent. A patient in his 80s with a history of Hodgkin's lymphoma required a red cell transfusion, and the request stated the need for irradiated blood. But unfortunately, non-irradiated blood was issued remotely through the Hemobank, and the requirement was irradiated at collection, but was identified by the healthcare support worker at the patient's bedside. So at least this patient wasn't transfused with non-irradiated blood, but the investigation showed that the flags in the LIMS system was not uniform and it caused confusion. And this is because in their LIMS, some flags were for information only, whilst others needed direct action. So I think having an understanding of what the flags are there for and making sure that you're using them appropriately and correctly is really important. So the next case is from 2014, and a pregnant woman, 19 weeks, was having a liver transplant. So the red cells that were requested and transfused was not CMV negative because the blood transfusion lab was unaware the patient was pregnant. So on our request forms, it has, I'm sure in many of your ones, it has a section for, is this patient pregnant? And that's obviously really important information for us in the lab in terms of special requirements. So the requester did not select CMV negative or indicate the patient was pregnant on the form. And then this was discovered when it was documented later on the second request form after the red cells had already been given. And there was no historical record in the transfusion lab for this patient. So this case indicates that even though the patient's coming into hospital, they might have different conditions going on. They might be pregnant and having a liver transplant. So be mindful of the patient's whole situation. Sorry about that, some background noise. The next one is, so John Sutton has just said, if the limb blocks you, what would you do in an emergency situation where there are no irradiated units on site? So the limbs, we would have to do a concessionary release. So that would need, if it was an emergency situation, you would issue the units and then get the concessionary release after. But you would issue those, get the concessionary release, and you can issue them, but you have to put in a comment. So it's quite hard. It lets you know that you shouldn't be doing this. So you have to put in an audit comment, and we would normally put in the haematology registrar that we've spoken to that's agreed this to happen. So it doesn't completely block you, it just makes it very hard, and it alerts you that it's not, it doesn't want you to do this, but obviously in emergency situations, blood is better than no blood. And look, in terms of those concessionary release forms, these are kept, and we have to put details of what the reason was and the haematology registrar that's approved it as well. So case 3, and this is from 2014, and a child with sickle cell disease received 2 units of red cells that were compatible but not phenotype matched for RH and K, and a further 2 units were also given 6 years later, not phenotype matched. So following on from this, 6 months later, there was a further request, and it was noted that the patient had developed anti-BMC. And once the RH phenotype was done, it's been identified that the patient was Big C negative, and that initially been transfused a Big C positive unit. So it turns out that the BMS had failed to follow the SOP and perform a phenotype prior to the red cell issue. So it would be interesting to find out if the clinical team had alerted the BMS to see if they had sickle cell disease. And I think that's why it's really hard, because it's about communication. We need to be told of these conditions. Also, I know in our hospital, RH and K, we have the cards available, so we can do that. And another thing perhaps we could have done is seen if that patient was on SPICE and they had an extended phenotype done. Ideally, they should have had an extended phenotype done before any transfusion, or 3 months clear of transfusion to identify what their phenotype was, because you wouldn't want the donor cells to interfere with that. And because they developed an antibody, it can then affect their blood provision in the future. So the final case I've got today, I've picked all the ones that I think relate to our session today. So a telephone request was taken for a 10-year-old girl, but the full details were not entered onto the telephone request form at the time of request. The request was taken by a lone overnight worker who was interrupted by a bleep and did not complete the task and fully look up the request on LIMS. So subsequently, the LIMS became unavailable due to planned downtime, and a second BMS later issued the red cells whilst the LIMS was still unavailable. So they've done their checks. They checked up the in-house special requirements on the backup file, which stated that she needed CMV negative and irradiated cellular components. And this was written on the request form, so that's great. The prescriber has understood their responsibilities and they've put that on the request form. A red cell unit was cross-matched, issued and transfused. And when the LIMS was back up and running, it was noted that there was also an additional requirement for K negative units due to the patient's gender and age. And this had been overlooked and a K positive unit had been transfused. So this again just shows you that even though patients have got one special requirement, you need to look at the patient as a whole, because they may have different special requirements. So in this case, because she was a female under 50, she also needed KEL negative products, as well as the other special requirements of CMV negative and irradiated. So thank you for listening, guys. I hope you found this useful for your practice. It really has been a back to basics, and I enjoyed researching it because I learned some things myself. A lot of the information that I have spoken about today is in the BSH guidelines. They're really useful for issuing blood or anything blood transfusion related. And also NHSBT provide a lot of fact sheets and mythbuster sheets, which are also really handy and helpful. And it's quite concise information, which is really nice. So just if you've got any questions or any discussion points that you want to talk about, then feel free if you want to raise your hand or in the chat. I hope you found it useful.
That was great, Sam. Thank you very much. I hope you all enjoyed this. I think this is it for today. So our next meeting is on the 24th of November. Topics to be confirmed, so please do watch out for our emails. We'll keep you posted on that, and social media as well. Please do give us your feedback, because we do rely on it to provide these kind of topics in terms of what do you guys want us to do, what sort of topic would you like, and in terms of antibody ID or any other topic. I think somebody got their hand up. I can't see you. Would you like to come in?
Hi, it's Rahila.
Hi.
Hi, I just want to say it was a very, very fantastic presentation, done quite well. And is it something that I could possibly share with some of our MLAs? It gives very good examples, so thank you, Sam.
Of course, thank you very much for your feedback. So like I said, so this will be uploaded onto our YouTube channel, so you can access that. And the presentation will be also uploaded on the JPAC website. So just give us a few days perhaps, and then that should be available for you. Chloe, do you want to come in?
Sorry, is that me? Did I raise my hand?
Hi. Oh yeah, you did. Did you not want to speak?
I did want to, but I didn't realise I'd already done it. I was just going to ask, we had a patient yesterday actually that had CAR T therapy, and they had sent down a special requirement change form for irradiated units, but they'd also requested CMV neg, and I just wanted to ask if that's typical for CAR T therapy patients, because I know we obviously don't use that therapy much on the NHS, so we don't see it often. I hadn't seen it before.
Sam, did you want to take this question?
So when I was doing my research, it was kind of the understanding that sort of only neonates require CMV negative cells, but perhaps as it is a new therapy, they're sort of starting to look into it a bit. And perhaps that consultant has more information on the patient and they feel that they require CMV negative products. When I was doing my research, I didn't see it, but as I say, it can be, it's a new therapy, so the special requirements are always changing.
Great, thanks, Sam. If there's any other questions that you guys are not clear, please feel free to email either myself or Sam, and I'm happy to share her email address. Any other questions from anyone? So Anas has put in the feedback form in the chat, so please do complete that at your earliest convenience. We do always ask if any of you would be willing to give one of these talks on the next sessions. So if you have an interesting topic that you would like to share with the rest of the group, please put your email in the feedback form and we'll get in touch at some point. Thanks very much, and enjoy the rest of your afternoon.